Hello, this is Dr. Ford Brewer with Prevmed, Heart Attack, Stroke, Disability Cancer Prevention. If you're on a statin, or if you know somebody on a statin, ask them why they're on it. Usually they'll say my cholesterol was too high and it improves my cholesterol. In fact, that's the standard reason for putting people on cholesterol. We think there's a more important reason, and I'm going to show you the data. The information's out there in the public. It's been there for 20 years. Yet, when you go to your cardiologist, your internist, your family practitioner, usually they put it on there for LDL. And there's a reason for that. The standards are all written around LDL level. Now, are we nuts looking at inflammation and heart attack and stroke and statins? No, we're not. Again, I'll go through some of the data with you today. So Paul Ridker started a whole lot of this and has been a major focus on this from day one. Pardon the image problems. I needed some new toner. I got it, and it's a lot better. Paul Ridker is a very smart cardiologist at Harvard, Brigham and Women. So here's one of the studies that shows inflammation and cardiovascular risk. This was a meta-analysis. It looked at a bunch of studies. All these are studies here. Like, you may have heard of some of these. Mr. Fit, Waskopf, which I'll talk about a little bit later, the Jupiter trial, several other trials. And as you'll see on here also, Paul Ridker was very much involved in a lot of these. Without getting into the science, here's the thing. You're looking at coronary heart disease, MI, which is a heart attack. A couple of them looked at stroke. Now, this dot is the estimate from the analysis of the study, how the statistics came out, where the risk is. This was the estimate based on, it could be, if you look at a bell curve in terms of risk and probabilities, it could be anywhere along this line. If that line crosses this one, then there's really no statistical significance. But look at that. All these studies, none of the lines crossed. C-reactive protein, inflammation is clearly a risk factor for heart attack and stroke. And again, that's 20 years ago we started seeing that. Here's another way of looking at this out of the Framingham study. Basically, we're looking at LDL and C-reactive protein. Again, without getting too deep into the data, this basically shows C-reactive protein risk for heart attack and stroke is not a function of LDL. So again, if all we're paying attention to is LDL and not inflammation, then we're barking up the wrong tree, as my southern ancestors used to say. Okay. Now this is an analysis, an editorial after Waskopf's came out, the West of Scotland trial, and it was written by a couple of very smart people from Harvard, Gavin Blake, who was a colleague with Paul Ridker. So again, you're probably noticing a pattern. I'm going to take a quick digression, by the way, and tell you that Paul Ridker just made the headlines again with inflammation, anti-inflammation, and prevention of heart attack and stroke. It's called the CANTOS trial, C-A-N-T-O-S. See my video on it? Basically what they did was they tried Alaris, which is a heavy-duty anti-inflammatory. It's used for autoimmune arthritis diseases. Sure enough, it prevented heart attack and stroke. But here's the problem. For every life that it saved with heart attack, stroke, and even cancer, it took back with serious infection. So that kind of drug is not ready for prime time. But as you're going to see here, the statins work. In addition, some of the blood pressure medicines work as well, like the ACE inhibitors. So that's why we tend to go with those old style drugs. A minute ago, I showed you the title page on an analysis of Waskopf's by Gavin Blake and Paul Ridker. Basically, they're going through several things. First of all, they say, look, The impact with these statins in Waskoff's was more than you would see with LDL lowering. Number two, the impact on the size of the plaques was not huge. Number three, if you look at these changes, they're greater than what you would have seen with LDL. And finally, if you look at stroke, you had a big decrease in stroke, and LDL is not that big of a player in terms of stroke risk. So what's going on here? Well, maybe it's inflammation. And in fact, sure enough, you look on the next page of this, this editorial, and that's what it's showing. The decrease in the added decrease in heart attack and stroke risk is happening because of a decrease in CRP, C-reactive protein, the best marker of inflammation that we had at the time. We've got some better ones now, and I've got a couple of videos on those. Microalbumin creatinine ratio, myeloperoxidase, MPO, Plaque 2, PLA 2. Now, so a competitive journal, you've got to have something fairly good to get these guys to publish it in their journal. And this was the Jupiter trial. That was a trial, again, headed up by Paul Ridker. I believe Gavin Blake was involved with this one, with him. But basically, what they did with Jupiter was they took the logic that they'd formed from Waskoff's and the other trials. I'll show you the logic behind this in just a minute. But the bottom line was they showed that rosuvastatin prevented vascular events and decreased C-reactive proteins. If you've listened so far, you're thinking, so why does this matter? I'm on a statin, I'm on Lipitor. That's the vast majority of patients that are on a statin that come to me, and there's very clear evidence that Lipitor doesn't provide. It provides LDL impact, but not anti-inflammatory impact. If you're a female, or if you have insulin resistance problems, carbohydrate metabolism problems. Well, half of us are female, and by the time we're age 60, half of us are have insulin resistance problems. By the time we're 65, maybe 60 to 80% of us have some insulin resistance problems. So all this Lipitor is great for LDL, but it's not impacting, for us, for the majority of us, our inflammation. That's why this is important. So, Jupiter, let's go back and look at that and understand the design around it. So they took people who had not had a previous cardiovascular event. They had low LDLs, and they maintained low LDLs, but they had high C-reactive protein. They gave them rosuvastatin. That's the generic name for Crestor, and had a huge decrease in their heart attack and stroke rates. Another question you may be having is inflammation. I mean, whenever I hear inflammation, I think a boil, or if you're a little bit more connected, you may say rheumatoid arthritis and lupus and maybe Crohn's disease or Hashimoto's or ulcerative colitis. Some of these inflammatory arthritis and GI and endocrine diseases. You're right. But you can also get that with the plaque in our arteries. So this is a schematic of plaque in an artery. This is the intima layer. You get plaque in there, quite often your immune system starts saying, we need that plaque out. So it does to the plaque what it does for any other tissue that it doesn't want there. It starts to send cells in, send antibodies, what we call cytokines, which draw more cells. It releases enzymes like Plaque 2, which we look for, or myeloperoxidase, which we can look for now. and they digest that plaque. Now, where is that plaque? It's not here in the lumen of the artery, the inside. It's between this single cell intima layer and the structural support for the artery, a muscle tissue called the media. Here's some real pictures of it. Here's a person that died with a heart attack. So here's the media, that muscle layer. Here's the intima, that single cell layer that keeps it slick and keeps it from clotting. This is where the blood flows. And this is all brownish, yellowish, grayish plaque. It's a waxy substance, except for right here. Right here you can see it's a liquid substance. This is a blow-up of it. This is a liquid substance that has been liquefied by this process I showed you in the last slide. Cells are coming in, they're releasing enzymes, they're dissolving this plaque. That your immune system thinks is okay. However, here's the problem. It's right under the intima layer, a very thin layer, and if this breaks through here and touches the blood, it causes a clot. Excuse me, it's not the clot that kills you. I mean, it's not the plaque that kills you, it's the clot. Well over 80-90% of strokes and heart attacks occur in an artery that was open prior to 1 minute prior to the event. And again, here's how that mechanism happens. Intima, this is the intima layer, and as you can see, it's very thin. This was one of those areas, this is the lumen, the area where the blood was flowing. This was one of those areas where the blood was liquefied. It had been attacked by the immune system. This is all plaque over here, but it hasn't been attacked. It's not brownish. Here you see another area where you've got some hot plaque starting up. Here's another thing that you see. There are cracks in the intima. You can find that with what we call a microalbumin creatinine ratio test. And here's the other thing. This is a clot here. That hot plaque flowed out, touched the blood, formed a clot. The majority of this clot broke off, went down, and killed the patient with a heart attack. Other parts of this clot went back up into that area that had been full of hot plaque. So again, if you're on Lipitor, think again. Think about other options. Think about options that impact your inflammation. This is Brewer, Prevmed, Heart Attack and Stroke Prevention. Thank you.